Good morning. My name is Dr. K.V. Chalam. I am Chair of Ophthalmology at Loma Linda Medical School in Los Angeles, California. And today I'm going to talk about the advances in retinal surgical visualization that kind of summarizes the history of the wide-angle systems and various nuances that are necessary to apply that during retinal surgery, and the advantages and the challenges that one may face during the retinal surgery itself. So as a surgeon, obviously, there are multiple things you need to know regarding this topic. First of all, talking about human retina and how much retina is there in terms of surface area, and how do we measure what we are seeing. Factors, biological and technical, that actually influence what we see during surgery, and the obstacles in visualization related to various organs that is in front of it, which is what are the things in cornea that can complicate the visualization, what are the things in pupil that can complicate the visualization, and how do you overcome also the spherical shape of retina. It would be very nice if it is just a flat screen. It's very easy to see. However, when you have a spherical screen, then you have resolution issues, aberration issues, and also depth of focus issues that may complicate not only visualization, but you're making decisions based upon the visualization in a 3D fashion. And so your hand-eye coordination, how does it overcome the challenges and deliver optimal technical delivery of the maneuvers you're trying to do? So let us start with the first one. How much is actually retina is present in a human eye? We're talking about a average eye which is 24 millimeters in length or diameter. And so the surface area of the retina, as you know, is not there in the front of the eye, obviously cornea, then the limbus and the pars plana. And as you see on the right-hand side, from a teaching point of view, I call it number 6 is the key. Roughly, from the center of the cornea to the limbus is around 6 millimeters. From the limbus to the ora serrata is around 6 millimeters. And from ora serrata to equatorial region is 6 millimeters. So we're really talking about a 18 millimeter circumference in the front and 18 millimeter circumference in the back. So for a 24 millimeter length eye, the circumference, half circumference is around 36 millimeter, or the total is around 72 millimeter. So everything boils down to number 6 and its multiples in mathematical terms. And we're really talking about the first 12 millimeters, then no retina. So the next 24 millimeters, you have retina. And the most difficult to visualize is the area between 12 and 18 millimeters. That is in front of the equatorial region because of the spherical shape. Since we're viewing the retina from the pupil, so the back surface of the 18 millimeters is relatively easy to visualize up to equator, marked by the vortex veins. But the 6 millimeters of retina that is in front of it to ora serrata is the difficult one because of the spherical shape and its related aberrations. You also have more temporal retina than nasal retina, and these tend to be even higher, larger in size in myopes, and smaller in size in hyperopes, depending on the length of the eye. And it's really crucial to understand the optics of the retinal viewing. So this is an example of a wide-angle opto systems where you can get the photograph of the entire retina. And as you can see in the central part, this is a 3D view. The central part is the central retina. The right side is temporal retina. The left side is nasal retina. And then superior nasal as well as inferior nasal, superior temporal as well as inferior temporal. And as you can see the curvature, this is not a flat surface. It tends to be a lot more flatter in the posterior pole and a lot more curved, obviously, anterior to the equatorial region. And so how do we measure the visual angle? and the eye angle. This is somewhat confusing to the audience in the world because the companies that advertise tend to use the eye angle as a measure of your retinal measurements. On the other hand, it is actually the visual angle that is extremely important to the surgeon during visualization. And as you can see on the left-hand side, the nodal point, which is located roughly 0.5 millimeter in front of the lens, is the nodal point in which the measurement should happen. So with that in mind, you actually only have 160 degrees of retina. And beyond that, the rest of it is anterior to the retina, which is pars plana, and the rest of the anti-segments. If you look at this figure 2, which is basically an eye angle, really here you're taking the central geometric point of the eye as a place from which you're measuring the amount of fundus. As you can see here, in this situation, you basically have a 360-degree retina, not 180 like I mentioned. And then in the 360-degree, equatorial region is roughly around 200 degrees, 180 degrees, and then a little bit anterior to that, which is very easily seen, what is commonly advertised as 200 degrees. The 45 degrees and 30 degrees that we are referring to in fundus cameras is related to the eye angle and not the visual angle. It's very important to understand this distinction so that you can actually understand when people advertise the lenses and the amount of it they can see based upon the angle. If the advertisement says visual angle is up to 160 degrees, that is panoramic view, that's the most you can see with a wide angle lens. On the other hand, if you use the fundus camera analogy, then you really have to see almost to 280 degrees to be able to say you're seeing the entire retina. And this is really important and crucial to understand. So this is a picture that kind of illustrates what I just mentioned. As you can see, the target, the nodal angle, so which is basically the visual angle, the sigma v is what it is shaped here. And whatever you measure from there is the visual angle. On the other hand, if you measure from the eye angle, which is sigma e, E stands for the eye angle. So that is what most of the fundus cameras notate for advertisement purposes. So as I mentioned, you have maximum amount of 170 degrees of retina in this particular way if you measure in a visual angle matrix. But on the other hand, if you measure in the eye angle matrix, it would be 240 degrees. So let me go back to the fundamentals of the ophthalmoscopy and how do they apply to the visualization during surgery. Direct ophthalmoscopy system, just like a direct ophthalmoscope. When you use it, you're basically, the plano-concave lens modality is what you're using, the direct ophthalmoscope. That basically means you're neutralizing the corneal curvature to make it flat. And once you do that, automatically the image that you see is very direct. But then the amount you see is really limited by the size of the pupil and the angle, and which usually limits you to no more than 30 to 45 degrees. Of course, this is useful because the stereopsis in this particular mode is extremely good. So if you're really doing anything close on the optic nerve or a maculum, like a macular hole or an epiretinal membrane, a flat lens has a much better light transmission as well as a much better stereopsis, which is really crucial if you're peeling thin membranes and the depth of them. So 50 odd years ago, when the vitrectomy started, this was the only thing that people had access to. So here you're seeing basically a plano concave lens made of either glass or plastic, usually housed in a ring, a sutured ring. I'm really talking about the early 80s and the early 90s, where we used to suture the lens ring to the limbus with a silk suture to house it, and then use this plano lens to put in there, which is called as Landau's lens or lens without a name, or you can even use just a cover slip. You put a viscoat or a viscoelastic material and you put in that. That automatically neutralizes the corneal curvature and allows you to see the fundus, especially the posterior part, fairly easily. But as I said, the area that you can see at the most, even by rotation of the eye, is only 20 to 30 degrees, or at the most 4 square centimeters. Remember, in the beginning of the lecture, I was basically saying the entire retina is around 12 to 13 square centimeters, but you're only seeing 4 square centimeters, and that is a problem because then you're missing the rest of the retina. So one of the challenges we used to have is basically, have this lens ring, which takes around 5 to 10 minutes. Then you take out, and sometimes you can have bleeding at the edges. So in order to circumvent it, one of the things we tried to do was, can we add a foot plates? So that way you don't have to switch a ring, and just with the mere placement of the viscoelastic drop, and you can put the lens on, as you see in the right-hand side of this particular slide. So that way you can get it without any need of an assistant and without also any problem of the corneal bleeding that one may encounter. Just for illustration, I put here where somebody had previous surgeries done and you're having this bleeding that can usually mess up your visualization by contaminating the viscoelastic that is covering your cornea. And also, when you're doing pediatric cases, this is an important consideration. In those situations, you reduce the size of the foot plates, like you see in the second part of this particular slide. So the left one is for mature adults, and the right one is for pediatric surgery patients. And the optics of it is fairly simple, as you place it. But you can also add a little bit more of angular visualization by using a prism at the edge of it. It's like having a Landis prism lens, in which case you not only see the posterior pole, but because of the prism, the image is extended in that meridian by another 15 degrees. So you can expand this by around from 4 centimeters to 5.5 centimeters. However, at any given time, you can only see a one quadrant of this 5.5 square centimeters at a time. So for example, you look at the inferior retina, then if you have to look at the temporal retina for example, in a left eye, you have to rotate it clockwise so you can get the temporal view. And so, another 90 degrees rotation, you get the superior retina. This is cumbersome, not pleasant, but at least, in times when you want higher stereopsis in a particular area, this is a maneuver an experienced surgeon can use to visualize the retina. Then there is also a problem of illumination in the direct lenses because you only illuminated the light that is perpendicular to that. So if you want to illuminate the retina, even though you view it, if you don't have any light, that's not a good. So we also modified and put a notch in it so you can, certain cases, especially if you're doing dissection in the anterior vitreous, like an anterior PVR case, you can put a light source at the edge, like I'm seeing in the third part of this animated drawing, where you can see the peripheral retina in a particular quadrant. So beyond the direct ophthalmoscopy systems, which does not require any inversion of the microscope, sometimes this is relevant in surgeries you do in camps or in areas where technically things are not really available. The direct system is extremely easy to carry, does not need an inversion, and you can carry out at least the work in the posterior pole if that is a pathology that you're trying to address. Now let us move on the next challenge of seeing this area of around 7 centimeters that you're not able to visualize with the direct ophthalmoscopy systems. So this was, starting in around 1990. So, there are a lot of advances in the systems, and then I'm going to go over various systems and the advantages and disadvantages. I'm going to start with the optical principles before I go into the practical aspects of each of the systems. Imagine the same thing like a direct ophthalmoscopy with a handheld lens, handheld direct ophthalmoscope with an indirect ophthalmoscopy, which we use, which revolutionized the retinal practice starting in the mid-60s and early 70s, where you can now look at the peripheral retina using an indirect ophthalmoscopy system. However, the image is inverted, and which takes some amount of training from the examiner, especially more so for a surgeon, because not only you're viewing like in a clinic, like an optometrist or an ophthalmologist, but you're also executing based upon the data that you're getting through the image, and the technical aspects of delivering like either depression or cutting or lasering, that means that need to be more precise and more accurate because your maneuvers are a function of what you're actually visualizing. And if you don't see good, you can do more damage than good. So this is an animation that is kind of comparing the indirect system versus a direct system. As you can see, V is that represents the direct ophthalmoscopy that I described earlier, which is around only 4 square centimeters of retina. With indirect, you can see A to B, which is now around 7.5 to 8 square centimeters. You still have 4 centimeters that you don't see that is anterior to the equatorial region unless you scleral depress, and which is a painful procedure in the clinic, but in the operating room, because the eye is anesthetized, is relatively more um, easy to do and less traumatic. So I'm just bringing the picture of the indirect ophthalmoscopy to remind the surgeons that this is the principle that is used in the wide-angle systems. As you can see here, this is a field size in indirect ophthalmoscopy extended A to B by using a condensing lens, which is in this case is like a 20 diopter lens that you're doing in the clinic. Now, if you do the same in using a 28 diopter lens, it is your angle is a little higher, but your magnification is a little lower. Now you extrapolate that to magnification. Magnification is important because a 30 diopter lens only magnifies your retina 2 times. And so that is a problem because at that magnification, you can't really, have the resolution for carrying out any membrane dissection. So we have to expand the magnification as well as expand the visual field. So what if you use a 150 diopter lens instead of a 30 diopter lens? You can increase the visual field a lot more, but your magnification becomes much less. It's only 0.4 times of the normal retina. So that is a starting point from where we start. And then now you go and take advantage of. But on the other hand, as you can see, now you can see 104 degrees measured from the nodal point. And that's great because that means you're seeing around 10 square centimeters of retina now instead of the 5 square centimeters. But this is not practical without a magnification, and that's where comes the microscope. So a field of view of a particular lens is a function of the diameter of the lens and the dioptric power of the lens. So if you take it now, the indirect systems produce inverted image, the upright and left-right corrected image, you have to preserve correct orientation and depth perception. And you also, more importantly, preserve level of illumination for you to carry out and take advantage of this wide angle viewing. You're able to accomplish by putting a much, much more higher power lens. So then there are two things that you can do. So there are inversion prisms. This is a prism pair that is incorporated with an attachment to your microscope that can invert your view. And as you can see in this particular animation with what I'm showing here is the inverter added. So by this clip that you can either invert or re-invert depending on what you're actually doing in the case. So what this does is in addition to your lens, so your lens increases your surface area that you see, your microscope increases the magnification so you can actually see the entire retina. And then this inverter, which is the third component, it re-inverts the image so you can comfortably look at the posterior pole without having to worry about it and do whatever is necessary to accomplish the surgical goals. Then I'm going to go to the optics of the image formation, as you can see here. So now let me put back all the three things. Number one, we used a very thick lens. This is 150 diopters. What does it do? It increases your visual angle. So that basically means the amount of area you can see. You remember I mentioned earlier, you have 160 degrees of retina from aura to aura all around. So this allows you to see up to 150 degrees without any manipulation. That's number one. So the image is formed between the microscope and the lens that you're putting on the eye. So that image then is basically inverted. So using the inverter, then you re-invert the image. So you get the corrected image of 160 degrees of retina which is roughly around 10.5 square centimeters of your retina with a microscope. And this is revolutionary because remember, when we started with the direct lens systems, you're only able to see 4 square centimeters. And as you all know, most of the pathology, especially in retinal detachments, or PVR, lies anterior to the equatorial region. And so to visualize that, and more importantly, to understand the three-dimensional relationship between your retina, your vitreous, and your choroid, this is really crucial. And remember, this is also not two-dimensional, it is three-dimensional. That means you have 12 meridians. So you have to examine it various areas to understand the mechanical forces that are causing the pathology. And unless you visualize them properly, then you can't really deliver the necessary dissection to accomplish your surgical goals. Added to the complexity, your vitreous is, acellular and avascular and had no color. So, movement of the dynamic movements is what allows you to perceive, various aspects of the pathology so that as a surgeon, you can take care of whatever is necessary to fix the problem. And this is a higher close-up, so in terms of the distances, where is this image forming? And as you can see here, this lens is basically attached to the cornea. So you're basically 7.8 or 8 millimeters where this 150 diopter lens is placed. Remember, the focal length of this 150 diopter has to be conjugal to the nodal point for you to be able to get good stereoptic image with great resolution. And so the image will be formed around 6 millimeters in front of the lens towards your microscope. So all in all, the image is formed from the corneal surface around 14 millimeters from cornea to your microscope, where your microscope zoom has to focus for you to get the good image. Remember, so this is the entire parts of the system. As you can see here, the eye, the lens, the contact lens or a non-contact lens you put in front, and the image that is formed is now captured by your objective lens of the microscope, gets re-inverted with the stereo inverter, and present to you binocularly, just like in your binocular indirect ophthalmoscope, to the surgeon, which allows you to see. There are two other points that I need to mention here. In terms of the focus and also in terms of the zoom. Remember, your microscope has a zoom capability varying anywhere from 4x to around 12x. So you're trying to magnify. If you use less magnification, you see more of the area. Use more magnification, you see less of the area, but more of the stereops for you to do surgery at a micron level. And this is crucial to understand. And the more you're familiar with it, the better your surgical results are. Added to that, you can control both the zoom and the focus of your area visualization with your foot pedal, which is integrated. And that's great to accomplish the results and understand the advances in retinal surgery. So this is a little bit more detailed lens structure here that is usually used. You have a neutralizing corneal curvature. You use a viscoelastic of some kind, especially probably a Elon because of its clarity and the ability to stick. And then you have the radius of curvature, the size of your lens. And remember, the visual field is a function of the diameter. But you have one other limitation here. You also want access to your ports without any intrusion or encumbrance from your lens. So there is some limitation of increasing the diameter of your lens. And the maximum we can do is only 18 millimeters, as you can see here. And that is the second component. It has to be airtight because otherwise you'll get temperature change and condensation, which will also compromise the quality of what you're seeing. So let me reiterate again, your field of view of what you're seeing of your retina is a function of the diameter of the lens and the dioptric power of the lens. Now, for example, can you increase the dioptric power from 150 to 220? So you can actually see the entire retina without any depression, all the way to the ciliary processes, just from retrolental area one end to the other, which is like 180 degrees. Yes, you can. But the trade-off is that your illumination the intensity of illumination is decreased, and you need a much higher intensity to take advantage of that uh, increased field. And the way you can do that is by increasing the refractive index of your dioptric uh, of the lens that you're trying to use. And I'll show some examples of that as well. And as I already alluded to, large area of inverted retina, which makes you nauseated if you don't take care of it. And just to make it simple, as you can see here, this is a direct image of orbis. And when you do it with an indirect ophthalmoscope, you see the orbis this way, inverted and backwards when using an indirect lens. So you can do this with surgery. Obviously, you have to invert it, right? So, but on the other hand, if you're using a plano concave lens, like I talking about earlier part, you certainly can see the direct image, but your area that you see is very limited to the posterior pole. So this is one of the examples of a stereo inverter that basically re-inverts your image. It comes in mounts of whatever microscope you're using, both Zeiss or Leica, which are commonly used in United States and in the rest of the world. And they can certainly make a mount that is relevant to your microscope that you have with which you do your cataract and retinal surgery. And again, it has to be housed between the examiner or the surgeon and the microscope, and it's usually made so that it is easy to assemble as well as disassemble just with a screw. So now let us go back to the contact versus non-contact. So the lens that you're putting, what about if you just put a non-contact lens instead of a contact lens? And I'm going to go over various systems that are available, the advantages and disadvantages of it, and other aspects that may compromise your visualization of the retina. Well, I'm bringing some systems that are commonly used in the United States, but this is neither an endorsement. This is likely to be more of comprehensive than promoting one or the other. All of those systems have their own advantages and disadvantages. On the contact system side, you have the OAK systems as well as AVI system. And in the non-contact, you have much more variety. ReSight made by the Zeiss microscope, Merlin made by the OAK optical systems, Biome made by the Biome systems, IBOS fairly common, more commonly used in the European countries. So independent of what systems you use, you basically have two components to that. One is an inverter, as you can see on the left-hand side of this animation. And then the lenses that comes in different dioptric powers, depending upon what you want to use for. In general, they come in two sizes. The bottom one is a 140-degree wide angle. This is similar to a quadrispheric lens or a super quad used during your panretinal photocoagulation. And the other one is roughly a 70-degree lens. And this is very useful for any pathology that is in the equatorial region, and most notably like diabetic retinopathy and related traction detachments. Whereas the one in the bottom is a lot more useful for PVR cases and retinal detachment, where the pathology is most of the time located anterior to the equatorial region. And of course, if you don't have the, one of the problems, and I'm going to go over this again in each of the things, the non-contact system, on the other hand, the optics is very similar, except you have the lens in between held by an attachment to the microscope, as you can see here. Unlike in the contact system where somebody has to hold your lens for your optimization. And it gets tricky because you really need a good assistant who understands, who is familiar with what you're doing. And especially if it is a long case, it can be frustrating in the later parts of your surgery if your assistant doesn't know how to hold it. I have some solutions. I'll talk about it at the end in terms of advances to overcome this. But that is the main disadvantage of the contact lens system. So the non-contact system, basically this is usually a 90 diopter lens or a 120 diopter lens, depending upon, each system comes with 2 or 3 combinations, but most of the time they're not as wide as contact lens system because of limitation of aberrations of the edges. You have distortion at the edges of your surgical field, which can be a problem. So I'm giving some specifications here. You have basically around three lenses that are available, let us say in this Maryland system. One is 120 degrees, the other is 112 degrees and 95 degrees. And it's basically like a 66 diopter, a 90 diopter, and a 120 diopter lens. The bigger the dioptric power, or the higher the dioptric power, the more image wide angle you see. And the less the power, less you see, but more stereopsis, just by the nature of the optics of the lens. Yeah, the resight system, this is more popular and extremely because most people, half the world has Zeiss operating system microscopes. And so this is made by the Zeiss company. So naturally, it fits very easily with the Zeiss microscopes that you have. And as you can see here, it is a sterilizable attachment. That is a blue attachment here. And this is a hanging loop, steel loop, to which you have these two separate lenses. This is more of a 90 diopter lens, and the yellow one is more of a 120 diopter. And as I alluded earlier, the dioptric power, the smaller the field, but better resolution and better stereopsis. The other advantage of this system is it can be sterilized and in an autoclave in steam sterilization. And this is an important thing because a lot of places don't have the gas sterilization either available or allowable. And if you do large number of cases in a given day, this becomes an important limitation. And this is the biome system, something similar to the resight system. Yeah, as you can see, this is an attachment here, and the steel screw would allow you to focus back and forth, and the lenses are sterilizable since it's all steel with an autoclave. This used to be popular until the resight system came, but available in a lot of places. And so as you can see here, the biome system easily attaches to the microscope, 130 degrees, increased clarity, reducing need for contact lens. So in comparison, resight is 128, biome has 130 diopter lens, Merlin has 120. And number of lenses, there are two of them. Biome has only one lens. They also now come with a disposable one, those of you that can afford, where you throw away the lens once you use it. And then you have the Merlin has a wide angle, small diameter, and midfield lens, three lenses. So the advantage of the contact system, the one I alluded to, which is basically RV or VOC systems, the greatest advantage eliminates corneal astigmatism. If you have patients with keratoconus or corneal scars, this is really important. And also because of the attachment, the true curvature of the image enhances stereopsis. This is extremely important to understand because any image you get anterior to your equator is really, really subject to aberrations depending on the lenses you use. So it is one thing to observe the pathology, it is another thing to do things to eliminate the pathology. So you require extreme precision of your hand-eye coordinations with the instruments. For example, if you're trying to peel membranes or to dissections of very attached membranes, which are 50 to 100 times the strength of the retina, then it is extremely important you don't cause any iatrogenic holes in retina by your own mistakes. And that is a function of how good you can see. And more importantly, how good you can see the 3D space of the area you're working. And so that is really important to understand. So the more complicated case you are, the better your contact lens system's imaging is. For simple cases, it's not that essential, but for complicated cases, this is really important. Then the second part of it is in non-contact systems, corneal drying is a problem. Every 5 to 10 minutes, you need to wash out the agent that you use, which is usually a methyl cellulose solution you normally use. You need to wash it out because it gets crusty. You have to then put it back. Whereas with viscoelastic, that's not an issue because it's very nutritious to the corneal epithelium, and then you don't have to replace it, and your clarity of your image remains extremely um, detailed and good. Of course, those of you that do not have an assistant, you can have lenses. There are two, it comes in two varieties. One is a without a ring, so you can actually, without any foot plates, which you can put in a regular vitrectomy ring. But I prefer foot plates because that actually locks your viscoelastic and your image very stabilized. The other optical advantage of the contact lens system is the amount of area you see is much, much higher, much wider. 170 degrees of field, you can literally see, especially in myopic eyes, aura to aura, and even some parts of your ciliary body without any depression, which is very useful because distortion, depression, even minimal depression can produce distortion of the image in the area you're operating, which is not ideal. The second thing is from a manufacturing point of view, it is an aspheric nature of the lens, which is really done well by the Vogue company. And so this is important for you not to have any chromatic or spherical aberrations. It has two-element contact lens. Then the curvature of the image, the first element neutralizes your cornea, and your second lens basically is a 150 or a 220 diopter lens, which actually produces your image. And so the curvature of the image is preserved because the aspheric nature of the lens, keeps your curvature of the image that you're visualizing very realistic and natural. And of course, that is important because when you use your microscope to magnify the image, the better the curvature of the image, the better your comfort level. For example, not causing any cataracts when you're trying to, you can literally go to the opposite meridian without touching the lens because of the curvature of the image being nice and realistic and true. Well, what are the advantages of non-contact systems? They're unencumbered eye. So basically, there is no crowding in the area where you're operating. The second most important thing that made it very popular is basically dependent of the assistant because solo practices or even multi-group practices does not have the luxury of having an assistant that is trained all the time because you're operating in an operating room where you don't control the personnel and their skills, and while they may have general skills, the specific skills necessary for the vitreoretinal surgery may not be available. So that causes problems when you're doing complicated cases. And so the assistant becomes crucial. So one of the advantages of the non-contact system is you don't need one because you can see directly, nobody's holding a lens for you. And so the other advantage he has is there is no inadvertent pressure on the cornea because if it's in contact lens system and your assistant is not really understanding of what's going on, they can over press the cornea or underpress the cornea, cause air bubbles. So this is an advantage in the non-contact system. So what influences the field? This is the other part of it that's really important. So far we have covered in the times when everything is ideal. Um, you know, so what are the factors that can influence your field despite having a perfect system? So what can influence is lens is phakic or pseudophakic. Let me start there. Phakic, if you have any cataracts pre-existing, especially cortical scopes, spokes that can cause compromise of your visualization. And of course, pseudophakia is a different problem. While your central field may be very nice, your entrance pupil is limited by your capsular excess that is performed by the anti-segment surgeons. Sometimes they can be very small because it's easy to make a small capsular excess than a large capsular excess. And also sometimes there can be fibrosis or of the capsular excess ring, which can what we call as a phimotic anticapsule, which can limit your visualization. That's very important to know and understand. Sometimes you may also need to approach anteriorly and remove some of it to be able to visualize. The second important, not really well-known fact is the depth of your antechamber. Remember earlier I was talking about the nodal point. Imagine if your nodal point is, let us say, 4 millimeters from your anterior corneal surface, then the amount of area you see is smaller Then, for example, you have a very shallow antechamber where your nodal point is only 2 millimeters, right? So the more the nodal point moves anterior, the wider your visualization becomes. This is a practical tip that most people don't know. Sometimes if you're compromised and if it's a large myopic eye, you can do paracentesis and fill with the little bit of viscoat or Provisc. And so that allows you a shallow antechamber and much wider view. Then the second physics principle that you need to understand is also gas bubble. So often we do air fluid exchange halfway through, and after that you do whatever you need to do. So gas exchange allows you to increase your width of the angle for two reasons. One, gas pushes your nodal point anteriorly towards your surgeon. And number two, there is a change in the refractive index from solution, which is 1, to the gas. And so that also increases your visual field. It's like putting a high index contact lens. So that gives an advantage. Then the third thing is, of course, the size of the pupil itself. Sometimes you can have synechiae, and pupil is only 2 millimeters versus a 9 millimeter pupil. The bigger the size, the better wide angle you see. So, last one, the opacities of the posterior capsule. Sometimes people have cataract surgery done, and if you have glistening posterior capsule, you may not realize this, but that can cause depth perception or accuracy problems. One other thing that I also should mention is a phakic lens in a diabetics. Sometimes they can get very cloudy. So you have to supplement your infusion fluid with dextrose solution so that there is no, if you increase the sugar content, if somebody is hyperglycemic, like in diabetes, it can suck water into your lens and make it thicker and also make it cloudier. So the dextrose solution, what it does, it desiccates and influences to retain the clarity of your lens throughout your surgery. Limitation of capsular phimosis, which I already mentioned. But one other thing with the advent of multifocal IOLs, this can be also a problem because especially if the lenses are made based on the diffractive principles, where you have multiple rings by which they control the refractive power, so that can be also a problem. The other influencing factors, corneal astigmatism, as I already mentioned in the beginning of the lecture, like a keratoconus or irregular cornea from multiple surgeries, or somebody has a penetrating keratoplasty, or had a post-cataract surgical lens drops, that is an issue. Lenticular astigmatism, it's not very common, but it can be like an Alport syndrome, where your posterior, unlike the drawings that we all make, lens actually in human lens has a flatter anterior curvature and a steeper posterior curvature. So it's more like a cone. So from the nodal point, every millimeter you go away, there is an aberration automatically. And if somebody has an astigmatism based upon that, that can mess up your visualization. Then the spherical aberration of the indirect ophthalmoscopy lens itself. Remember, you're making 150, 220-degree lenses, which are extremely difficult to manufacture. So as you go away from your lens central point, there is some amount of aberration. And of course, with some learning curve involved, especially if you're starting using these things, so until you get comfortable. Then, of course, the paraxiality of the imaging system. That means we have what we call as a dynamic ophthalmoscopy. That means a tilt of 1 millimeter of your lens to one side increases the area of your viewing in the area you're working by at least another 10 degrees. And this becomes important in certain situations where you're compromised by the size of your pupil. As I said already, problem small pupil limiting wide view. What are the things that you can do? Undilated pupil, dilated pupil. As you can see here, the dilated the pupil, the bigger the amount of light, common sense. So what are the effect of the size of the pupil? And this is more of an optics question, but as you can see here, the bigger the pupil, the more you see. Air-filled eye, that's the next one I was talking about. So more air-filled, instead of going 104 degrees, you're seeing 130 degrees now. So it increases your visual field. Assistant skills. So to circumvent it, we have the foot plates attached to the flat lenses, as you can see here. So you don't need anybody to hold your flat lens. You just put a viscoat or, a Helan or whatever you have. It immediately takes care of it. So that's a great advantage. And then you can have operating lens systems. There are varieties. You have a mini quad, which is a much larger system. It gives you around 180 degrees. And Dynaview, this is specifically made for the pediatric patients. And these are the ones that you can put in ring instead of foot plates if you want stability. There are multiple ways to deal with this. These are available and each of them has a particular purpose. Especially if you're doing an ROP case, Dynaview is very useful. So I already talked about the non-contact system things. So we have a combination set now available, which is basically flat lens as well as a contact lens with foot plates so that you can actually easily do together. Sterilization limitations, depending upon, as I said earlier, steam sterilization can ruin your lenses, and simply soaking in a disinfectant is not allowed by some operating rooms. So one way to get around would be these lenses, the material is made so it is steam sterilizable at any given time, or these are disposable set which you can throw away at the end of each case. So in summary, you need to have the clinical points relevant to a clinician, other than understanding the optics and the physiology of it, would be your lenses should be perpendicular to the eye so that you get a coaxial image, which is useful for you to do maneuvers. Image should always be round. Then when you put a lens in, if you're getting an oval contour of the image, that means your lens is not perpendicular to the eye, is elevated in one area compared to the other meridians. Then another thing that is commonly not looked into is intraocular pressure should always be in physiological range. If it is high, then you will have corneal edema that will mess up your image very fast. Or if you are low, you can have DM folds, which can mess up your image. So always try to maintain the pressure of between 15 and 25 intraocular pressure, which is equivalent to if you're using just a pole, it has to be 40 centimeters of water above your operating room. But with now the various vitrectomy systems trying to control the pressure, and the limitation, of course, is you have to do closed ports. If you have open ports, they're not really accurate. So this is really important if it is a long surgery to keep your cornea clear. You don't want to peel your corneal epithelium. These are diabetic patients often, or retinal patients. You can have neuroparalytic pathology in the cornea and cause other problems you don't want to have. Then the sclerotomy site should be appropriate. Differential pressure on the sclerotomy site can also distort the curvature in that meridian and interfere with your stereopsis. So don't be heavy-handed. Don't you always use a wrist rest to rest the weight of your hand, and so that you can maintain a fairly gentle holding of your probes on surgical instruments. Well, there is one last thing I want to talk about it, and here is a system we designed. Well, can you take advantage of a wide-angle contact system without an assistant holding, which is the disadvantage? And then obviously we mix them together, and here is a video I want to show how this can be solved.
Hi, this is Dr. Kinza Ahmed, Seth Meyer, and Dr. Kakarla Chalam demonstrating the first hands-free wide-angle contact lens system for vitreoretinal surgery. This contact lens can be fitted to the existing biome fundus imaging systems such as the popularly used ReSight 700, as shown here. ProVisc is applied to the corneal surface to allow coupling of the lens to the cornea. The ReSight is engaged, the lens is lowered into position, and then docked onto the corneal surface. The lens and adapter are both sterilizable and reusable. Here is a side view of a surgeon operating using this lens system. We now switch to show you the microscope view utilizing this lens. Again, ProVisc is applied to allow the lens to be coupled to the corneal surface. The microscope is lowered to dock the lens in place. It is easy to tell when the lens has docked due to a change in the viscoelastic meniscus. Let us again see in slow motion the moment at which the lens makes contact. The lens system can now be used in standard fashion to carry out retinal surgery using the operating microscope foot pedal to control magnification and movement. Here, we show a case of a patient undergoing pars plana vitrectomy for non-clearing vitreous hemorrhage due to proliferative diabetic retinopathy. To contrast the view provided by our new contact lens system, here is a microscope view with the standard non-contact viewing system that comes with the ReSight. You can notice the optical clarity is somewhat limited by glare and reflections of the microscope light. This lens is also sensitive to fogging, which is not an issue in our new contact lens system. The contact lens system also provides the greatest stereopsis resolution of anatomy depth and eye curvature. The proposed lens system provides a 170-degree static field view in a phakic eye and a 180-degree dynamic view. The wide field view of this lens allows for easy visualization and access to the anterior vitreous for peripheral shave. For more posterior pathology, the microscope can be used to increase magnification with the zoom and focus buttons on the foot pedal as shown here. This allows easy visualization of the hyaloid for a PVD induction. Here, we demonstrate that the lens can also be used with the scleral depressor for depressed shave and depressed laser. The lens also provides excellent clarity during fluid-air exchange and eliminates view disruption from surface air bubbles, which occurs often with the non-contact lens systems. In summary, the contact lens system has the advantage of improving visualization by overcoming the optical irregularities of the corneal surface and providing a wider field of view with greater resolution and stereopsis than the existing non-contact lens viewing systems. Thank you for watching.
Anyway, I conclude this lecture with all the, in summary, I talked about the normal anatomy, ability to view retina, direct systems and indirect systems, and the advantages of various lens systems, and also an example how you can combine with a 3D printed adapter, that is submitted for publication, and hopefully everybody will be able to do on their own without much difficulty, where you can have a contact lens system without an assistant taking care of it. And I hope this lecture is very helpful.